Hi, you guys. Thank you for joining me on today's Ask the Egg Whisperer. I look forward to seeing patients all day long. I'm probably the only person that wakes up in the morning and says, I wish I could just go back and get into bed and not leave the house. I'm just like fired up each and every day. I know you're like, oh my God, toilet please, I'm gonna gag and throw up. But literally, I'm so happy to be able to help people who want to bring love into their hearts, into their lives, into their homes. So thank you guys for being here, and I'll stop being so cheesy right now and I'll just start getting to your questions. So Anna says, I am 39 years old with unexplained infertility. My AMH in August was 0.375 with genetic testing that was normal. I've completed 2 egg retrievals. The first was at 38 years of age and the second was at 39. Cycle 1 resulted in 12 follicles, 11 eggs, 11 fertilized with ICSI, and I got 2 day 6 embryos. Both were abnormal. One was a low mosaic aneuploid for monosomy 15, and the other was complex abnormal with 3 different things wrong with it. I did 21 days of birth control for about 12 days using then gonal 225, menopur 75, and then I increased to 100 with cetrotide, and then I did an HCG trigger shot. Cycle 2 resulted in 9 follicles, 6 eggs, 5 fertilized with ICSI, 1 day 5, AA blast, and 1 day 6. Both were abnormal. Day 5 with trisomy 13, and the day 6 had a couple things wrong with it. I did the same protocol, except I used 24 days of birth control and menopur and increased to 150 instead of 100 at day 8. I'm taking a prenatal CoQ10, vitamin D, omega-3, and I just started taking DHEA 75 milligrams today. My question is this: do I have hope in having a normal embryo? Any changes to the protocol you would recommend? Anything else I can do to improve egg quality? Thank you. So Anna, I know sometimes I make like certain suggestions and offer guidance about IVF protocols. And I know not every clinic has the same flexibility that I have. I'm kind of like 7-Eleven. And I've had some people say to me, Aimee, don't talk about yourself like 7-Eleven. I'm like, but you can find condoms here, right? Those transducer condom covers, but no cigarettes. But maybe there should be cigarettes in the collection room. Anyways, that's silly jokes. But what I'm trying to say is this. If you're a patient of mine, I would say, Anna, cut the birth control pills, no more. That could potentially be decreasing the number of mature eggs that your doctor is getting for you. See if that's an option at your clinic. It might not be, because people use birth control pills in IVF as IVF planning pills. And so, that's one suggestion I have for you. Suggestion number 2 is look at all the official reports, go to embryodiamonds.com and make sure you know everything you need to know about your embryos. And it sounds like you do, but the S in embryo diamonds, the S is the sperm, right? So what is the sperm quality on the day of the egg retrieval? Is this all egg driven, or is it possible that this could be sperm driven too? And so there's a test that you can do called the sperm DNA fragmentation test. And even if you don't want to do that, that's okay. You can ask your doctor to see if they have certain tools in the IVF lab and see what they think about them. And if your doctor says, I don't believe in them, just tell your doctor, well, I believe in you, but you don't believe in them, and I trust you, because they might have the ability to do something, or they find that something else is better. For example, there's something called Picsi, P-I-C-S-I, which sounds like a little fairy that just like sprinkles glitter over the eggs or something, or the sperm, but it's basically a more stringent way of picking out higher quality sperm cells potentially. And there's also another little device or tool called the Zymote chip. And you can go to Zymote Fertility. I have no relationship with any of these companies that make any of these things at all, not even like a little bit. So that's why I'm just suggesting that to you. So see if that's a tool that potentially your doctor can use in your IVF cycles. The other thing is, I don't see in any of the protocols that you used HGH, also known as omnitrope, is a generic name. So omnitrope is something that you might want to ask your doctor if they feel comfortable adding to your protocol. Perhaps they can do that as well. And then last but not least, I would say, in addition to the supplements that you're taking, consider taking NAD. True Niagen is the company that, I get it from, but you can get it from, and it all comes from the same company as far as where it's sourced. And then other companies just get it and license it from them. So those are my suggestions for you. And I would say the fact that you have a mosaic embryo tells me you almost had a normal. Don't discard that embryo. I personally, and again, like, talk to a genetic counselor, talk to your doctor, talk to the genetic testing company that did the testing for you before you make a final decision, and perhaps talk to a high-risk OBGYN or someone like that, or your OBGYN, about how they're going to monitor you in pregnancy to reassure you that the pregnancy is normal. But I give every embryo the benefit of the doubt, and I feel like that mosaic embryo could turn into a beautiful pregnancy, and I don't want you to think that you can't transfer that embryo. So if your doctor won't allow you to, be sure to find a doctor that will, quote unquote, allow you to. And for all of you guys who are watching right now,
It is really important when you do genetic testing of embryos to make sure you understand the protocol for reporting mosaic embryos and transferring mosaic embryos, because some patients don't know, but their doctor will not report if they have a mosaic embryo or not, and they're under this assumption that all their embryos are abnormal, when indeed there might be one or two that could be mosaic. Okay, and Anna, don't give up. I would probably consider doing 1 or 2 more cycles given the blast formation rate that you have, and especially the fact that you had a mosaic embryo, if that's something that you're comfortable doing. Otherwise, if you feel like considering other options, you can do it anytime and never look back and think that you didn't try your very best, because you truly have. This next question is from Alexis. Alexis says, hi, Dr. Aimee, I was diagnosed with endometriosis. I had laparoscopic surgery in August for it. During the surgery, this is what happened. They did a dye test and found that no dye. Oh, I froze there. Let me do that question again. So let's see here. It's from Alexis. Hi, Dr. Aimee. I was diagnosed with endometriosis. I had a laparoscopic surgery in August for it. During the surgery, they did a dye test and found that no dye went through my tubes. As a result, I was told that IVF would be my only option for children. During the IVF process, my doctor decided to do another dye test and found that my right tube is functioning normally. My left one is a mess, and as a result, I'm having surgery to remove it. If my left tube is removed, would there be a likely chance of becoming pregnant without IVF, just with my one tube? Alexis, that is a great question. Here we go. The side you ovulate on, I'm trying to show you that I'm flipping a coin, is basically like flipping a coin. Your body doesn't ovulate on the right side every odd month and the left side on the even months or anything like that. And it's not like you can necessarily target a certain ovary to ovulate in any given month. For example, if you were to take fertility drugs and I knew that one tube was open and one tube wasn't, I can't like send in a fertility drug to like just talk to the one ovary that I want to ovulate, that I want you to ovulate from. I wish it worked that way. But the reality is, yes, you could potentially get pregnant from a situation where you just have one tube open and one tube absent or are not open. However, it might be less efficient than if you obviously had both tubes that were open. The likelihood that an egg gets picked up from a side that doesn't have a tube over to the side that has a tube is extremely low. And when I say extremely, I've seen it maybe like 1 or 2 times in my, I was gonna say my fertile life, but also in my, literally in my fertile life, because ever since I've been a fertility doctor, I would call that my fertile life. And I've been a fertility doctor since I was born. That's kind of what I eat, sleep, and think of, daydream of all day long, is how to help people, and especially people like you. So the answer is yes, you can definitely get pregnant naturally, even if you have one tube that is removed. But I would seriously consider doing the inflammation testing. Maybe it just depends on how many embryos you have, and see if that would make sense and what your doctor thinks about doing that. And sometimes I coordinate the ERA test and the receptiva test on the same day as a laparoscopy for patients, so that you can get it all done at the same time when you get all the information back and then figure out what you want to do next. This next question is from Aisel. Is it possible to have low AMH with PCOS? If a person having an AMH of 1.1 at 33, can you predict her AMH after 2 years? Those are 2 really good questions. So number 1, can you have low AMH with PCOS? And the answer is yes. There's actually a certain genetic variant that people with PCOS could potentially have. It's called, I think, BIMP. I don't know if this is how you pronounce it, but it's BMP15. This is from studies that you can find in PubMed. And I think I'm right about that gene name, but I can't be like 100% sure, but I think I'm 99% sure that's the name of it. And I actually did some research into this because I had a situation where I'm like, this is strange. Like, this person has all the symptoms of PCOS, but then her ovarian reserve is on the lower side. And the answer is that this gene is related to both things. So people who have PCOS could also have inherited this gene and have a lower AMH, even though they have the symptoms of PCOS. And I would just think of it as like a metabolic issue. That's all, like if you're in that situation, you have something that's going on that is related to glucose, impaired glucose regulation, or some metabolic issue, and some issues with egg quality. So if you just deal with both things, then and get a diagnosis early enough, you might be able, especially at the age of 33, not might, you should be able to get embryos preserved for yourself, do egg freezing if you need to, as well. And I feel like when women have PCOS, and for those of you who have been diagnosed with PCOS out there, sometimes it takes years before you actually get to a diagnosis. And that's why just looking at someone and making assumptions about them is extremely unfair. And I wish I could be like, take a picture of yourself and send me a selfie and I'll know everything there is to know about you, but it just doesn't work that way. But I think if you have certain features of PCOS, sometimes people just think that you have PCOS and they miss out on the possibility that you actually might have low AMH and some metabolic issues that are PCOS related. So if someone just makes this assumption about you, and I see this all the time where people come in and they're like, I have PCOS. And I actually say to them, I actually don't believe it until I see it. Why do you think you have PCOS? And they're like, oh, my doctor says that I have cysts on my ovaries. And I'm like, well, that's not how we make the diagnosis. What do you mean by cyst? Well, I go in for an ultrasound, I have a big cyst. I'm like, well, that's not the cyst that we're talking about when we talk about PCOS. We're talking about little tiny cysts, also known as follicles. So it's really important to please confirm this ovarian syndrome and make sure you have the right diagnosis when you're talking about being told that you have PCOS. And then the other question about predicting your AMH after 2 years with an AMH of 1.1, the answer is yeah. I mean, typically for someone who's 32 years, your AMH in 2 years could still be 1.1. AMH levels basically decline very slowly over time for someone who's in their early 30s. And it isn't until like you're 37 and above that you might see more of a change from year to year or even every 3 to 6 months. This next question is from Shay. Shay says, hi, Dr. Aimee, I'm 44 and just beginning my journey to motherhood. I've been single most of my adult life. So let me see here. I've been single most of my adult life. So being a struggling single mother, that's hard for me to say. Those words are very hard together, was not in my plan for bringing a child in this world. I get it. Not, you guys, I don't want to say that out loud and make you think that being a single mother means struggling. It does not. But what Shay is saying, that for her, it might feel that way. At this point, due to my age, and I realize conceiving with my own eggs may be bleak, financially, I would be taking it on alone as well, but I'm ready to be a mom at 44. However, I want to get your thoughts on any options you think I should consider or pursue. Is egg donation the only option? I'm finally ready to take this step. So Shay, what I would say to you, there are a lot of creative ways of being a mom out there. So there's egg donation, certainly. There's embryo donation. There's also adoption. And then the other thing that would be cool, not cool, like I've done before, if this is acceptable to you, is maybe create a sort of co-parenting situation for yourself. Not that you're co-parenting and sharing, let's say, a child with, you know, in terms of a family unit, but potentially having a situation where you have more than one family that has siblings together that are raising them with one another. Or it doesn't even have to be siblings that are DNA siblings, but find other solo mamas by choice out there that you can parent with, so you're not feeling like you're a struggling single mother. I want to take the word struggling out of there, and I want to replace that word with thriving single mother. Okay, so that's kind of what I would want you to do. If you have not listened to Sarah Kowalski's podcast or gone to her Facebook page, please do. Her book is Motherhood Reimagined, and she is fabulous. And she has virtual groups that she hosts, and she does one-on-one coaching as well. And I think you'll learn so much from her. And a lot of my patients are in her groups, and I think they learn so much and get so much support from the other women around in that group. And so they feel like they're not struggling, but they're thriving. Okay. This next question is from Ginny. Okay, let's see if I can say all the words in Ginny's question without turning it into alphabet soup. Here we go. Hi, Dr. Aimee. I just found your Instagram account last October as recommended. It was recommended by an embryologist, Dr. Carolyn Kircho. Carol, she's awesome, through my IVF Answers webinar. I'm 38 years old. My AMH is 8.98. We've been trying to conceive through IVF for 4 years. I've done 5 fresh cycles, 2 frozen embryo transfers, 2 pregnancies, and no live birth. On the average, we have always had 8 mature eggs and 2 to 4 embryos by day 5. The 2 pregnancies I had always stopped about 6 to 8 weeks. Just 2 years ago, we found out that my husband has a varicocele, and then he had surgery right away, but since then his sperm didn't really change by much. Our doctor has been telling us the problem is the sperm, but sperm donor is just not an option for my husband right now. Would you recommend an egg donor? What other tests can we do? I'm also going to be doing some immune testing. I also want to know if I should do the ERA test. Thanks in advance. I wish I could speak to you in person. God bless you for helping women like me. So Jenny, let's break it down. You're a pretty incredible person. I mean, you clearly love your husband. Someone's telling you you need a sperm donor and you're just like, but what about an egg donor? I mean, that just shows I would say like how things are so not necessarily unbalanced, but like culturally, how women, I don't know if the word culturally is right, but I feel like women are more likely to give up their own DNA to satisfy their husband's needs or wants to use their own DNA, even when we're told that it's a sperm issue. Like I see this all the time. And there's nothing wrong with that actually. It just shows like what a loving person you are and how much you know, it sounds like maybe your husband might be against using a sperm donor. So in a case like this, I would have you talk to your doctor about doing a sperm extraction procedure. Don't worry, husband of Ginny, you would be either asleep or, you know, have local anesthesia around the area. And studies have shown, and I had Dr. Blake Evans on this show not that long ago in the last 6 months or so, and he presented data showing that in cases potentially like yours, doing a sperm extraction might increase the chances of having a higher pregnancy rate, live birth rate, and more blastocysts. So before you went to sperm donor or egg donor, you might want to consider that. And before you even did that, maybe take a look at the sperm DNA fragmentation test and see where his level is at before you make these big decisions. I don't know basically why your pregnancies always stopped, whether they were genetically abnormal or not. The likelihood is that they probably were, but I would go through the Angel method, angelmethod.com, and look at all the stuff there and make sure that you've ruled everything out, like an autoimmune issue, a uterine septum, for example. That would be important to me, and make sure you've done chromosome testing for both of you as well. So imagine you go through an egg donor cycle and the same thing happens with a batch of eggs from an egg donor. And then you would be pretty upset if like you hadn't done the test first before you made such a big decision to do that. I do think that doing the ERA test and receptiva test makes sense before you do a transfer again. You know, I would say yes to that. But I think the most important thing is, even though you've done all this work, you've done all these cycles, let's really nail down the diagnosis and make sure we're not missing anything. Like ask your doctor, have you ruled out a chromosome abnormality for me and my husband? Have you ruled out a uterine septum? Have you ruled out, let's say, adenomyosis is affecting, you know, the chance of an embryo from implanting? Like those are the kinds of conversations you want to have. And your doctor might have already like thought of all those things, but it's just so reassuring to just go through that list and be like, autoimmune check, anatomy check, genetics check, nutrition check, endocrine abnormalities check, lifestyle check, bam, Angel method, okay? I have all my little angels right here. I don't know if you can see them. Next question is from Theju. Hi, doctor. I've had 2 IVF cycles and both went in vain because I ovulated before my egg retrieval. In the first cycle, my IVF was converted to IUI because I ovulated before the trigger. I had 6 to 7 follicles, and out of them, 3 were over 17 millimeters. In the second cycle, they also noticed premature ovulation after going to egg retrieval and retrieved only 1 egg that was immature, and the follicle was 12 millimeters. Before ovulation, I had 6 follicles, 4 were over 17 while they gave me the trigger. The doctor didn't see any surge on LH level in my LH level on the trigger day. So I think, Beju, you're saying, what the heckity heck would I do if that happened to me? And I can tell you, I'd be pretty ticked off if that happened to me as a doctor, especially as a patient. I mean, going through all those medications, I mean, your medications alone from an IVF cycle are so freaking expensive. And I don't take a minute of anything that my patients go through for granted. And so that's why I do my very best when I analyze things like exactly the dose of medications a patient should take for trigger shot, the timing of everything, what your hormone levels are on the day of the trigger shot, whether we should add antagonist or not. So if you're someone who's ovulated twice on your doctor, here's what I would say. This could be a sign of egg quality, right? Like that could be an issue, and no matter what you do, it could happen again. But at the same time, some things that you could do differently would be to add an antagonist with your trigger shot. If you already did that, be sure to do it the next day. If you already did that, do it twice a day on the day of the trigger shot and twice a day the next day, and maybe even super early in the morning before your actual egg retrieval. The other thing that you could do is trigger at 34 hours rather than 36 hours. So all these things potentially could prevent the premature ovulation and hopefully allow you to get to the point where you can get and recover more mature eggs and be successful. Okay, this next question is from Bonnie. Bonnie says, hi, Dr. Aimee, my last IUI was in December. I took Clomid right before that and an Ovidril shot 2 days prior to my IUI. My question is regarding OHSS. I received, and for you guys who don't know what OHSS is, it stands for Ovarian Hyperstimulation Syndrome. I received a negative pregnancy test on December 18th and my period started 2 days later. Would it be possible to have OHSS even though I'm not pregnant? I have all the symptoms, but my doctor doesn't believe it's possible. I desperately want an ultrasound, but they won't give me one. I'm bloated, nauseous, fatigued, I pee all the time, I'm thirsty, and I'm super tender. Help. Okay, Bonnie, if your doctor is like, you can't come in for an ultrasound, I would just call every 5 minutes until you get one, literally. I mean, it sounds like you probably don't have OHSS, but you probably have big cysts from Clomid. Any fertility treatment can cause that, and there's no reason for you to suffer at home without having a proper diagnosis. And if your fertility doctor isn't going to help you, well, then call your local OBGYN. And then you say, can you call the fertility doctor for me? Because they're not paying attention to me. Can someone please help me? And I would just call them every 5 minutes until they do that for you. And that's what I would do for a patient of mine. So if, let's say, you called me and you had something done somewhere else and you were like, Aimee, this is happening to me and they're not calling me. And I'll be like, well, I'll call them for you. I know them. I have their phone number. I'll give them a call. So in your community, I bet your OBGYN knows your fertility doctor and they could be like, dude, can you just like not be that way? And she's having lots of pain from the treatment that you gave her and you need to deal with that. But at the same time, it's really important to go to the emergency room. And I know it's hard with COVID, like no one wants to go there, especially here in the Bay Area. But if you are having severe pain, and especially if you're having other associated symptoms like nausea and vomiting, and when you press on your tummy, if it really hurts, those are signs and symptoms of something that can be really dangerous called ovarian torsion. So we don't want you to have emergency surgery. We don't like emergencies nowadays. We want everything to be done during the day when everyone's like awake and ready to take care of you. And again, like no emergency, please. The only emergency that I like is, actually there's really no emergencies that I enjoy, not even a little bit. That's, as a fertility doctor, we basically have like 3 emergencies. An ectopic pregnancy, a cancer diagnosis, and the other thing that sometimes feels like an emergency is my treatment didn't work, my period has started, and a miscarriage. A miscarriage obviously sucks, but at the end of the day, we want everything to be as simple and straightforward as possible when patients go through treatment. And you want to be sure that your doctor's going to be there for you, especially when you're having symptoms. So I'm sorry, Bonnie, that they're not, but call them and call them again. As soon as you are done listening to me, I mean, now call them. You don't have to listen to me, call them. Okay. This next question is from Helen, and Helen says, aloha, I'm 45 and a half. I've had 1 IVF cycle resulting in 1 good blast, which was implanted but didn't take. Should I move on to donor eggs now? Or is there maybe still a chance with my own eggs? 7 were retrieved, 4 fertilized, 1 made it. That was 1 year ago. Thank you. Helen, you know what? You're a young, healthy woman. You're going to live another 50 years at least. I don't want you to look back and be like, what would have happened if I had tried 1 more time? However, I can reassure you that the likelihood of us being able to find a good egg at 45 is maybe about like 2 to 3%. Could you be a 45-year-old that still has a healthy egg left? It's possible. So I feel like if you're going to live the rest of your life wondering, do another cycle. However, if you're like, I'm ready to just move towards something that's going to give me a much higher chance of pregnancy, my suggestion is to move on to donor eggs. Take all the time you need, talk to a psychologist, look at all the different egg banks that are out there, look at egg donor agencies, look at my freeze and share program, just kind of get yourself educated about all the possible options and then get really excited about what you're going to do next. And if you're not excited, it's not time yet to do it. That's my recommendation. Okay. This is a question from Alyssa. Alyssa says, hi, Dr. Aimee. Thanks for all you do and for sharing your positive, infectious energy. Thank you, Alyssa. I'm 29 years old. I've been trying to conceive for 1.5 years. I've had my tushy checked and everything is normal, except for possible scarring around my tubes. It could potentially be endometriosis, but hasn't been confirmed and there's no male factor. I just finished 4 rounds of Femera with my natural cycle and I'm not pregnant. 3 fertility doctors are saying IVF and saying we have a very small chance to conceive naturally, but I am just having a hard time accepting it. What age and factors determine your decision to recommend IVF to a patient? How long is too long to try to conceive naturally? Is there anything I can do to improve my chances naturally? And thank you so much for answering my questions. Happy New Year. Alyssa, let me tell you what to do. First of all, I would suggest, and it sounds like you're someone who's like so many of my patients that are like, if I could avoid IVF, I'm going to do that. Very few people, I should say, have seen me on their bucket list. Very few people, not coming out right, very few people get married. I mean, not that you need to get married to have a baby, guys, but very few people are at the altar saying, oh my goodness, I cannot wait to do IVF and meet Dr. Aimee. Like, I know none. So the fact that you're like, I'm not excited about doing IVF, I'm like, welcome to the club. Like, yeah. So that's my strategy, to figure out what your diagnosis is and see what we can do to help you get pregnant without anybody's help, so that if we end up needing treatment, you are not in a situation where you woulda, coulda, shoulda, and wished you had done more testing and learned more about yourself. You basically told us the diagnosis. It sounds like there's scar tissue around your fallopian tubes. The fallopian tubes are basically the embryo transport system that takes an egg and sperm that have fertilized, and that embryo then travels down the tube for about 5 days until it sticks and grows inside the lining of the uterus. If there is scarring, the likelihood of there being egg pickup on that side is really low. And so that is an issue. So it's basically like there's a fertilization issue because the egg and sperm can't meet when they're scarring at the base of the fallopian tube. So how do we fix that? Well, there is a surgery that you can do. It's called a laparoscopy. And a laparoscopy is a gynecologic procedure that is very commonly performed. It's considered minimally invasive. It's still a surgery. So, you know, with surgery, there are risks. So I'm not going to minimize that. But I would say for the most part, the risks from a laparoscopic surgery are going to be really low. So I would find a wonderful laparoscopic surgeon in your area. There is a subspecialty of OBGYNs called MIGS surgeons, M-I-G-S, minimally invasive gynecologic surgeons. So ask your doctor, is there a MIGS surgeon you can refer you to? And if they're like, how did you know what a MIGS surgeon is? You can be like, I've done my research. I know what's up. And so, you know, start interviewing surgeons and find someone who is going to be like, yeah, I totally believe in your fertility and I'm going to do everything possible during a laparoscopic surgery to improve your fertility. And that's it. And so this is the thing though, like there's a possibility, and you should be open and aware to this fact that at the time of surgery, they might see that your tubes are actually kind of on the disease side, and not that you have a disease, but they're affected and kind of, I'll just use the word like a little bit abnormal. And if they're abnormal, it sometimes is recommended to remove the tubes. And so that's a really hard thing to have done before you have embryos frozen. But sometimes it's recommended to remove tubes if they're really abnormal to prevent something called an ectopic pregnancy with an embryo transfer. So you want to have those conversations up front, say, hey, let's just go in, let's diagnose, do whatever you can to improve my fertility, but don't remove my tubes, because I think, knowing myself, that I'm going to be a little bit depressed if I wake up and there are no embryos waiting for me. And then you'll do the embryo creation process, get your embryos frozen, and then you're going to do another laparoscopy to get rid of the tubes if they're causing a ruckus in there. Okay, so this next question is from Kate. Kate says, I'm 31 years old and was on birth control pills for 15 years, which affected my lining. My second IUI was canceled due to my lining not passing 4.6 millimeters. I am now on letrozole and 2 milligrams of estrogen. I've been doing acupuncture and yoga for a few months now. I have no other factors contributing to my infertility. Do you have any advice? So Kate, it's really rare for birth control pills to affect the lining. I mean, birth control pills are in your system just for a short period of time. And once you're done, they're out of your system and they shouldn't affect your uterine lining. So I'm thinking there might be something else going on. If your lining is truly that thin, let's take a look at something called a hysteroscopy, go in with the camera and have your doctor look around and see what's going on. See if there's any scar tissue or anything like that from maybe some undiagnosed previous infection. Chances of that are really, really small and rare, but I would do that if it were me. The other thing is if you haven't had an HSG, you could do that as well, and they could, kill two birds, one stone. Stupid analogy. I swear I'm not good at these analogies tonight. But basically what that means is they can take a look at the cavity and your fallopian tubes at the same time and see if there's scarring in both places. In a case like yours, I would also potentially suggest you taking aspirin daily, 81 milligrams, L-arginine, vitamin E. That could help. And very rarely I've actually seen people have thinner linings on letrozole. For the most part, we think of Clomid as thinning the linings, not letrozole. So depending on how thin your lining is with this treatment, you might want to consider gonadotropin injections rather than just taking fertility pills. That might help raise your estrogen endogenously, meaning the estrogen that your own ovary produces, even more so than what you can do exogenously by swallowing estrogen. So think of that as another option. This next question is from Violet. Violet says, hi, Dr. Aimee, I'm 41. I had an egg retrieval last month. I had 40 eggs being retrieved. Yes, that is bananas. You're right, Violet. It is bananas. I had 23 mature for ICSI, 16 fertilized, 6 blastocysts by day 5 and 6. All 6 were biopsied, tested, and frozen. 2 were normal. 1 was good, 1 was fair. First, do these numbers seem reasonable given my age? Second, we only want 1 baby. Do I need to consider doing another retrieval, or are my odds for a successful transfer decent with 2 on ice even at my age? I had 1 successful pregnancy 20 years ago. So Violet, I think you're in really good position to be successful with the 2 embryos that you have. I would say if you're ready to transfer now, go ahead and do it. And the likelihood of you being able to get another normal embryo if this next transfer didn't work would be pretty high in the next 3 months, I would say. And patients who are 41 who are able to make 2 genetically normal embryos, I think in the next 3 months, you'd probably be able to make at least 1 if you were to need to cycle again. So I don't necessarily think that you need to do another cycle right now, but I would say, if there's a chance that you might want still 1 more baby, you might want to do 1 more cycle now in case you might change your mind in 2 years, because that fair graded embryo might not give you what you need in 2 years from now. The other thing that I would say is at 41, even having 16 fertilized eggs and embryos that resulted in 6 blasts on day 5 or 6, having 2 genetically normal is you're probably like in the 5% club. I think most people are lucky to get even 1 normal at 41. So the fact that you got 2 is pretty outstanding. So that's pretty awesome. And then the other little word of advice is just make sure you're being told if any of your embryos are mosaic, so you don't make the assumption that they're abnormal when they might have a chance for turning into a healthy pregnancy. Okay, this next question is from Laura. Laura says, hi, Dr. Aimee. My name is Laura and I'm 31. My husband and I have had 2 miscarriages and no live births. Laura, I'm really sorry about that. And thank you for sending in your question today. We got pregnant quite quickly each time, 3 months with the first, 5 months with the second. My first loss was a trisomy 16 and the second one was a monosomy 6. A trisomy 16 and monosomy 6. The second loss was a partial molar pregnancy. After being monitored for my molar pregnancy, I've been officially cleared to try to conceive again. I have low AMH and a high FSH. My AMH is 0.9, my FSH is 10. I'm taking a prenatal and CoQ10. Do you suggest we try again or go to IVF? So given the information you're sharing with me, Laura, what I would say is that you don't need to do IVF to have a healthy pregnancy. However, given how the human experience is for so many people when it comes to building our families, I think based on what you've learned is that maybe in your situation, it might be a good idea to do IVF and genetically test embryos so you don't go through another miscarriage. And this would also allow you to preserve embryos for the future. So doing IVF with PGTA, I think in a case like yours would make perfect sense to me. I have cases like this and situations and patients who come to me with this exact same question. And what I say to them is this: look, you still have a chance of having a healthy pregnancy. I want us to kind of think through a hypothetical where the same thing happens again and you get pregnant and have another miscarriage. Can you live through that? I mean, I know the answer is I'm going to be okay because we have to be. But if the answer is, I'm going to be so devastated, I'm going to be so depressed, I'm probably going to have to quit my job, and who cares about the job, but you know what I mean, I'm going to have to quit my job, my relationships are going to get worse with my partner and my loved ones, and I'm going to have more stress, more anxiety, more PTSD. I cannot have another miscarriage. If that's how you feel about it, then I would say do IVF and don't look back. However, I do have some patients that are like, Aimee, I would rather not do IVF. I mean, what do you think? And I would say, like, well, if you're okay, potentially with, and no one's ever going to be like, okay, but if you accept the risk of, or accept the likelihood of this next pregnancy possibly turning into a miscarriage, and knowing that doing IVF might have prevented it if it was a genetically abnormal miscarriage, if you're okay with that, I would say, then try naturally and it's okay. But you have to have all these conversations ahead of time, because I don't want you to be like, oh, I regret trying naturally. I could have done IVF and genetically tested these embryos. I could have made embryos for my future so that I didn't have to do this again in like 2 years. But I wish the science was as perfect as sometimes I make it sound, because it certainly is not. And there's still so much to be desired with the technology that we have. But right now, we just have the murkiest of crystal balls, and that's chromosome testing of embryos. But it sounds like you've had embryos that have been, pregnancies that have been tested. And we know that in your situation, it seems like the chromosomes are the issue. And hopefully by putting an embryo in that has normal chromosomes inside your uterus, that should hopefully reduce your risk tremendously of having another miscarriage. So this next question is from D. D is saying this. Hi, Dr. Aimee, I'm having difficulty having a second baby. My son is 21 months old and I'm now 38. My AMH is 0.97 and my FSH is 6. We started trying 10 months ago. I've had 1 miscarriage resulting in a DNC and 2 chemical pregnancies. So that's basically 3 pregnancies that have been abnormal. After the last chemical pregnancy, we started Clomid, and we've now completed 3 cycles of Clomid. The last at 150 was with IUI, and I'm still not pregnant. I've done an autoimmune panel, which was normal. Thyroid levels are normal. We only want 1 more baby. What do you recommend? I'm losing hope. So D, it sounds like what you're experiencing is very similar to what a lot of patients experience as we get older. I would say your levels suggest that you should still have a pretty darn good chance of having another healthy pregnancy in there. When you've had a DNC and chemical pregnancies, I want to know, what did we learn from the DNC? Was genetic testing performed on that pregnancy? And if the answer is no, it was not, then I would say, let's look at your chromosomes and your partner's chromosomes and make sure we're not missing something there. With the biochemicals, we want to make sure we're not missing a tubal pregnancy issue. So do an HSG and see what's going on with your fallopian tubes and make sure we're not missing the fact that you might have a hydrosalpinx or a blocked tube, and these biochemicals could potentially be recurrent ectopic pregnancies. And then talk to your doctor about repeating your hormone levels, your FSH, estradiol, AMH, and look at the husband's sperm and see if his DNA fragmentation is abnormal. And if at the end of the day, IVF is acceptable to you, you would be in a perfect, like your situation is something that like IVF with genetic testing would hopefully treat, meaning by creating embryos and testing them, this could give you the highest chance of pregnancy possible and the lowest risk of another miscarriage. So I hope that advice is helpful. This next question is from Liddy. Liddy says, hi, Dr. Aimee. Thank you for being so amazing. My name is Liddy, and I'm just 32 years old. I've been trying for 11 months now, and I went to an RE doctor, and he gave me the most devastating news. He said that my day 3 FSH is 23, AFC, which is antral follicle count, is 6, my AMH is 0.78, TSH 1.4, LH9, estradiol 16. He also did a day 21 progesterone test, which was 9, and DHEA level, which was 181, and my vitamin D is 24. I just did a genetic test. I also did an HSG, which is normal, and I've been crying ever since. The doctor said he will help, but with my level, it's very hard to respond to medication. Watching your video gave me so much hope, but I'm still worrying. I'm just starting the CoQ10 that you recommended. What do you think is wrong with me? What do you think I should do to improve my egg quality and lower my FSH? I'm willing to try anything that will help me improve my fertility. Thanks in advance. So Liddy, this is the thing. You're 32 years old. You have 6 follicles. You have 32-year-old eggs. That's a really good thing. You have 6 of them. That's awesome. Like, I just focus on that positivity right there and the things that we have, and not look back on the things that we woulda, coulda, shoulda, woulda had. Okay. So at 32, even though your FSH is 23, I can tell you just from experience, and I can tell you a whole bunch of IVF doctors would say that as well, you should still be able to get genetically normal embryos if you were to do IVF. So I would preserve your fertility, I would make embryos, and I would just focus on what you have, which is the 6 follicles and your young age. And the FSH level is just saying, I'm so glad you're seeing this level now so you can do something for your future. I mean, that's all your FSH is saying. So we still have to be open to all possibilities and have only positive and practical expectations. Certainly, sometimes the FSH level is high and you don't get what you need in the first batch of embryos. And I've been there before with young people too. But I would say, find a doctor that will root for you, cheer for you, work hard for you, not give up on you. And if you haven't done mindfulness stuff like join Fertility Rally, join Resolve, find a meditation practice. You can join, let's say, Josephine at Lurie's meditation workshops. Like all of those things, I think, can really help decrease the anxiety and help you feel joy as you're going through this process, because there's so many things that are stressful out there in life. And I don't want you to feel like you're walking around with the number 23 tattooed in your forehead. And I think sometimes that's how these levels make us feel, is that like they are ingrained in our brain and they're constantly in our ear, like it's not going to work, your levels are horrible, your eggs are going to be bad, and we should turn around and say our window is still open, I'm going to be a mom one way or another, everything is okay, everything's going to be okay. I'm so glad that I have access to these great doctors and the fact that I can take CoQ10. But I would say the best thing that you can do is live your healthiest life, and it sounds like you're doing all of that already. And I would preserve your fertility and do whatever you can to do that, okay? This next question is from Jenna. Jenna says, hi, Dr. Aimee, please help. I'm 34 and recently had my first IVF cycle that didn't go as well as I had hoped. My AMH is 0.8, my FSH is between 8 and 10, my AFC is around 10. I had 5 eggs retrieved, 3 mature, 1 frozen embryo. I did a week of birth control, 375 of Follicle, 20 HCG LH, and 6 units of Omnitrope with Ganirelix. We're hoping to do another egg retrieval. I'm 34, recently had my first IVF cycle that didn't go as well as I had hoped. My AMH is 0.8, my FSH is between 8 and 10, my AFC is around 10. I had 5 eggs retrieved, 3 mature, 1 frozen. I did a week of birth control pills, 375 of Follicle, 20 of HCG, 6 units of Omnitrope with Ganirelix. We're hoping to do another retrieval in the next month or 2 and not sure what to do with my protocol. And my RE doesn't seem too sure either. What would you change to retrieve more mature eggs to make more embryos? Any help would be very much appreciated. Thank you for everything. So my suggestion is this: don't take a week of birth control pills. I don't know that a week is really that big of a deal, but I would say 1 or 2 days of birth control pills, not a big deal. Maybe a week for you might have been too suppressing. Rather than using just Follicle with HCG, I know a lot of people use HCG in place of Menopur, but use more of the HCG or dilute HCG LH and then less of the Follicle. So maybe by adding more Menopur, you might be able to get more mature eggs. Grow your eggs maybe to 22 millimeters in size, push things of 1 more day, see if you should take a higher dose of the trigger shot, and then maybe start HGH now, maybe twice a week before your next IVF cycle. And those are some of the things that I would do in a case of yours. So I hope that helps. I'm so glad you have 1 frozen embryo already, and I'm glad you're open to doing more. That makes perfect sense. This next question is from Lauren. Lauren says, my husband and I have been trying for a little over a year now. I'm now 30 and he's 32. We got pregnant in May, but quickly miscarried. We recently decided to get help and I'm determined that my AMH is 3.3 and his sperm is great. My first appointment with a fertility specialist, however, showed that I have an open follicle on my right ovary during menstruation. So we waited a cycle, and I think what you mean by that is a cyst. We waited a cycle and now my right ovary is fine, but my left ovary had a cyst also. The specialist said it was small enough that we could try letrozole. When I asked if my ovaries are defective, he didn't answer. Needless to say, I'm feeling discouraged. Why can my follicles not be closing up when they should? What should I do? Okay, Lauren, I think what you're describing is something very simple, and that's called, ovarian cysts that come and go. So every time we ovulate, we make a cyst. And when you come in for a pre-scan before you start treatment, that's what we're looking for. We're looking for a cyst. And when I say cyst, people are like, oh my goodness, does this mean I have cancer? And I always have to say, no. I start off by saying, this is a cyst check. We make a cyst every time we ovulate. Most of the time they go away at the start of the cycle, but sometimes they don't. When they don't go away, sometimes they can secrete estrogen, and that estrogen can interfere with the cycle and make it so that we have a wonky cycle. And we want to make sure we're moving forward at a time where we know all the information and have the right set of expectations as far as like how you're going to respond. I just don't want patients to waste time and energy on medications if the cycle is not going to be a good enough cycle to move forward with. So that's the purpose of looking for a cyst. But it sounds like you're perfectly normal. It sounds like your doctor said not to worry, and I wouldn't worry either. You can see that old cyst of ovulation and have it not be a cyst when you go in for the cyst check at the beginning of the cycle. And again, it doesn't mean anything bad at all. They're just saying like, oh, look, that's where you ovulated from last month. It's not like, oh, look, that you're defective and there's something wrong with you. So don't think of it like that. Think of it like they're just kind of sharing everything there is to know about your body, and you can still move forward with treatment. It doesn't sound like it's a bad thing at all. This last question is from Jumana. Jumana says, how can I improve egg quality in a short time? Would avocados and walnuts help? So I wish that eggs were like sperm and we could actually do something like that and improve egg quality in a short period of time, but we can't. Our eggs, they just kind of change over time, and as we get older, it's called ovarian aging, our eggs run out. I actually got into a YouTube, not a fight, but a discussion with someone on YouTube, and she posted something on one of my shows saying, stop saying that eggs go away. And I'm like, well, eggs go away. And she said, stop saying that. I was like, they go away. And we went back and forth, not just kidding. And she said, if you pray that eggs won't go away, they won't go away. And I'm like, I pray every day, and I can tell you eggs still go away. I mean, I pray for my patients. I have all these, I visualize things for my patients with my patients, and still they go away. And the thing is, there's no amount of avocados and walnuts that will prevent your eggs from going away. Does eating healthy help with our egg quality? It could. Does exercising help with our egg quality? It's possible. Do those things help with pregnancy and giving us a higher chance of having a healthy pregnancy? Yes, I mean, that's for sure. But I don't want patients or people out there to think that if you do certain things with your lifestyle, you will then be able to control and improve your fertility. It just doesn't work like that. On the show, I talk all the time about taking supplements like CoQ10, NAD, stuff like that, prenatal fish oil, vitamin D, and we know that these things can help improve pregnancy outcomes and decrease issues like neural tube defects and other types of things in pregnancy. But as far as improving egg counts and quality, I don't know why in some patients they work better in others. And at the end of the day, you can't make the assumption that we have any control over our egg quality and count. The only thing that we can do is have control over the information, and then we can make decisions, and we have control over the decisions that we make as far as what we want to do to empower ourselves based on the information that we learn and the doctors that we see and the treatments that we do. And at the end of the day, we got to let the control go, because fertility is not something that you can literally control. You can understand it, but not control. So I'm going to go to your live chatted questions right now. And here we go. Let's see here. The first question is from Rhea Bloom. You're the best. Will an RE do a thyroid panel, or should I go to my internist for that? And the answer is most REs will at least check a TSH level. And in my office, what I do is I have the lab set up for TSH with a reflex for the full thyroid panel if the TSH is elevated. So the answer is most REs will. Next question is, let's see here. I'm wondering why I got 18 eggs retrieved and 11 were mature. What happened to the other 7? Why weren't the rest mature? And that's just normal stuff. That's part of the pyramid. Not every follicle will have an egg, and not every egg that comes out will also be mature. And so when you look at the sizes, so if you guys go to sparklingeggs.com, you'll see my sparkle checklist, and you'll look at the size of the follicles, and that usually should predict whether the egg will be mature or not. But a lot of the times, if an egg that comes out isn't mature, even though the egg is really big, I think that that egg probably wasn't a very viable egg, even though it came out of a follicle that should have been a mature one. Someone's asking about CD138 in a biopsy to determine if endometritis exists. How do you identify it? So it's done with a special stain. CD138 refers to a stain that's done by a pathologist in a pathology lab, and they give a report after they stain the cells. Next question is from Allie saying, hi, could starting Clomid 1 day earlier affect dominant follicle recruitment? I did both cycle day 2 through 6 and cycle day 3 through 7, always recruited 2 follicles in the former, but only 1 in the latter. And the answer is yes. It is possible by starting the medications in your case on day 2 that you might have had a better response in more than 1 egg. So this is another question about IVF, and it's, we speak lots on prep for egg retrieval, but what about prep for frozen embryo transfer and the best implantation food supplements, things one can do? So yeah, I mean, I think if you think about strategy, you think about embryo creation, and then you think about embryo transfer preparation and then transfer. So that's all part of the egg whisperer diet. So the E is embryo transfer preparation. And so doing implantation testing, looking at the cavity, make sure you're as healthy as possible, not just physically, but mentally, spiritually, and in your relationships before you transfer. All of that's important. I have lots of resources on my website for nutrition, meditation, so you can go to my blog and read more there about the different things that I talk about and recommend. Someone's asking, hi, Dr. Aimee, have you ever started a cycle in the follicular phase? My doctor wants to do this. So yes, most cycles are started in the follicular phase, but what I think you mean is luteal phase. So after ovulation, the answer is yes. I've done that very successfully before for other people. Someone's saying, I'm in SoCal and would love to be your future patient. How could that work for IVF? So just go to draimee.org, fill in a schedule a consult. There's a contact form there, and you can do it there. Could labs and ultrasounds be done in SoCal until I drive up north? The answer is absolutely. We coordinate everything remotely. Next question is, hi, Dr. Aimee, I'm 36 and diagnosed with secondary infertility, and my AMH is 3.78, LH is 5.05, FSH is 6.39, and I just had a submucosal fibroid removed a few weeks ago. Would I have better odds with IUI or IVF? And the answer is, anyone who's over 35 would have better odds with IVF. I mean, anyone in general, IVF gives you a better chance of pregnancy. But my thing is at 36, unless it sounds like you already have one baby at home, I would say it might make sense to do a couple cycles of IUI first before doing IVF, unless you want more children than just one more after this one. Next question is, hi, Dr. Aimee, I just had my day 21 progesterone blood work done and it came back as 134.8. Do you have any insight on that high of a level? And my insight would be like, wow, that is a very high progesterone. Are you taking progesterone? I'm not too worried about it, but that's a healthy, that's a very strong ovulation that you had, and that's it. I'm not too worried about it. There's no such thing as, what I tell people, there's no such thing as too much progesterone. It's like water to a marathon runner. It doesn't hurt anything except potentially you'd be symptomatic. If you're taking it, you might want to consider stopping it. Next question is, hi, Dr. Aimee, what are your thoughts on embryo transfer with a vaginal ultrasound rather than abdominal? I saw an interview from another doctor saying it's more successful. And I would say, if that doctor feels like it's more successful for them, then that's what they need to do. But most of us don't do it that way. Most of us do it with abdominal ultrasound guidance. There is a case where doing it vaginally might be more helpful. And there's, I've done it maybe once or twice, but that's if the cervix is really, really hard to get through. Then sometimes using a vaginal probe with the guidance that way could be better. But for the most part, abdominal ultrasound all the way. Let's see here. I've asked about the ERA. Do you do the ERA for all your patients or only if they meet the need? And the answer is I talk to everyone about it. And some patients, even if they have several embryos, choose to do it. And some patients who have one embryo choose not to do it. So it's a very personal choice as to whether someone wants to do it or not. Someone's asking about a specific place to buy CoQ10, and I recommend that you go to Theralogic's website. NeoQ10 is the version I recommend. It's 1 to 2 capsules per day, and you can use the code TUSHY, all caps, TUSHY, not that I need to spell that word, but I did. This next question is, should I try to get pregnant naturally before my next IVF? My last 2 retrievals have resulted in abnormal embryos. Now I'm scared about the abnormal embryos. And the thing is that if an abnormal embryo forms, the most likely scenario is that you have a negative pregnancy test. So I wouldn't be scared. However, depending on your age, having an abnormal pregnancy is scary because that could cut into your fertile life and your fertile window. So I always tell my patients, as long as you understand that and are okay with it and are okay with not freezing embryos for your future, and it sounds like you've already been through so much, you just never know when you're going to ovulate a golden egg. So I would say go for it if you feel like you want to try naturally. I don't think it's dangerous. What would be considered a normal follicle count on day 10? And it just depends on what your age is, what your AMH is, because whatever your follicle count is normal for you. There's no such thing as an abnormal follicle count. I'm going for my second IUI after having a miscarriage from my first IUI at 8 weeks. What should I do to prepare my body for the second round of IUI? So it sounds like you probably still have a really good chance of getting pregnant for IUI, but I would go through the Angel method. I would go through the Tushy check and make sure we haven't missed anything. Looking at the genetic piece, the anatomic piece, the autoimmune piece, all of that's really important. Next question is from Karina, who says, I have PCOS, but I'm overweight. I'm taking the recommended supplements, dietary changes, and still don't seem to be ovulating. Do you have any recommended treatment paths? The answer is yes. So if you're not ovulating, despite all of that, you can consider Femera. And then if you're still resistant, meaning your body isn't ovulating on that medication, you can add 3 other things, basically, metformin, naltrexone, and dexamethasone. So these steroids can help your ovaries be more responsive. You can also just make sure that you've healed your PCOS, healed meaning HEALED, Look at all your hormone levels, and if your testosterone is high, for example, you want to bring it down with medications, for example, first before you try another treatment plan. Next question is, what's a possible cause of a chemical pregnancy after an FET if the embryos were PGS testing and the lining was perfect? So the other possible causes could be related to interactions between the genes in the uterus and the genes in the embryo that we can't control. Okay. The other possibility is inflammation at the level of the lining of the uterus, and that's why we check for silent endometriosis. The other thing is you might not have the right timing as far as progesterone goes, and that's why the ERA test is important. The other possibility is scar tissue of a uterine polyp or a submucosal fibroid, something like that, that can potentially block implantation. So those are all the things that we think about in a case like that. Casey is saying, is IUI a waste of time for unexplained infertility? And I would say, Casey, like, really ask your doctor, like, what are the possible explanations for me? And then talk through the 3 questions. What do I want? What is it going to take? And am I willing to do it? And if you want, let's say, 2 kids and you're 39 years old and you're planning on doing IUI, you might want to regroup and talk about IVF. However, you might want to say, well, if it's going to take doing IVF to have 2 kids at that age, maybe I'll consider doing IUI and then change what I want to 1 more baby. So the answer is no, I don't think it's a waste of time. But when you're planning a treatment with your doctor, talk about what's my diagnosis, what are the chances of success with this treatment, and will this help me satisfy what I want and help me get it. When you refer to fish oil supplements, do you mean DHA only, omega-3s and DHA? So the Theranatal supplement or prenatal has the amount of DHA that I want patients to be on. There's also another vitamin. It's through Orthomolecular. They have a really nice prenatal too. Next question is, if you lose weight too quickly, like 30 pounds in 1 month, will it hurt your egg quality? And the answer is, it could make your hair fall out. I mean, losing a lot of weight really fast can affect your hair. Not that you're asking about hair, but I just brought that up. It could potentially cause you to have irregular ovulation, maybe, but it doesn't necessarily have to. It just kind of depends on what your starting weight was. So if you started off on the heavier side and lost 30 pounds, I don't see it as being disruptive. However, if you started off, let's say, normal weight and lost 30 pounds, intentionally or unintentionally, it could be disruptive, and it might push you towards something called hypothalamic amenorrhea. So this next question is actually about hypothalamic amenorrhea. I have hypothalamic amenorrhea diagnosed by an OB/GYN. Are my chances for a successful IVF cycle lower than someone else? The answer is no. Typically, people with hypothalamic amenorrhea have a really healthy egg count, and that's a good sign for you as far as what's to come. This next question is from Allie. Allie says, my vitamin D tested at 30, but my RE said between 25 to 35 is fine as per the Endocrine Society. Yesterday, you mentioned you target vitamin D of 40. Should I up my current daily dose to 5,000 IUs daily? So I would say a level of 30 is at the low end of normal. I do aim patients, no pun intended, sorry, for patients to be above 40. And so you can't really, it's really hard to overdose on vitamin D. It takes a while for it to go up. Take it with your, excuse me, oh, that sounds horrible, your fattiest meal of the day. Look at my cute mug. Look at all my lipstick. That's so cute. Other fertility doctors and then me. I'm the unicorn on the pole. So yes. Someone's saying, your flowers behind you are so pretty. What's the occasion? There's no occasion, just patients that are really grateful that, or I should say, I'm grateful that I am so lucky to have patients that send me beautiful flowers. So this next question is, 2 months ago, I started to feel something was off, and I went in for a checkup, and I found a 9-centimeter fibroid, and my follicle count was 8. My AMH was 0.3, and I'm 30. How many cycles do I need for 2 live births? So at the age of 30, follicle count of 8, I mean, that's pretty awesome. I would also look at your FSH and estradiol, and I think that you might need 2 IVF cycles. You might be able to get the embryos you need with 1 cycle, but I would say maybe do 2, because the fibroid might come back and that might interfere with stuff down the road, and you might need more embryos to have 1 healthy implantation if the fibroid surgery affects your uterus. That's my suggestion there. Next question is, have you seen IVF work for patients 45 or over with their own eggs? And the answer is, it's really hard to find a good egg when you're over the age of 40, especially past your 45th birthday. I have seen it happen. I tell patients it's important to feel like you're given a chance to have a pregnancy with your own eggs, but you should know what the expectations should be from the treatment that you're doing. So when I have a 45-year-old patient, I just tell them, can you just repeat after me what you think the chances are? And it's important that we say the same number, because if my patient thinks it should be 100% and I'm like, 2%, then clearly there's a disconnect, and that's called misleading somebody. And I never want to mislead or misguide people. I want to make sure people know the real deal. Let's see here. I think that's it, you guys. So I will be back again this week, probably on Thursday. So be sure to send in your question to asktheeggwhisperer.com, and I look forward to answering them on Thursday. I'll see you guys later. Have a great night. Bye, guys.